discuss about Now we will discuss about the pathophysiology of the infective endocarditis. So this is most important points in pathogenesis of the infective endocarditis. So as we know, it's a bacterial infection. So what are those important valves which can involve in the infective endocarditis? So this is the sequence. According to the frequency of a valve involvement, so this is the most important which can be asked in any exam. So mitral valve most in common, then aortic valve, then tricuspid valve, and the pulmonary valve. So this frequency is according to the pressure. According to pressure. So those valve which undergo high pressure, so these are the first, like mitral valve, aortic valve, tricuspid valve. These valve have high pressure than pulmonary valve. So that's why these are the valves which can go in fact infective endocarditis. And what is the next point is infective endocarditis. So there is as we know, there is formation of the vegetations. So vegetations are the hallmark and pathognomic of infective endocarditis. And as we know, there is valve. So on the valve there is vegetation in which there is a formation of the bacteria, proliferation of bacteria and organisms. So this is the pathognomic sign, so which can be asked in any question in any exam. So this is an important point. So now what are the sequence of pathogenesis of infective endocarditis? First of all, there is endocardial damage and denudations. What how there is damage to the infective in endocardium? As we know, if there is any damage wall, for example, as I draw there, if there is any damage wall, so this is the, as we said, this is the damage wall, damaged wall. So as we know, blood, when blood comes from this or damage wall, any congenital defect in this wall, so as we know, this wall become narrow. So due to this narrowness, so blood comes from this wall in a very high speed. So when blood comes from flow with very high speed at the center and the produce turbulent flow at the periphery, so cause due to this high speed, this cause the endocardial damage and denudation of the endothelial surface. So high pressure put here, so this high pressure damage to the endothelium. Due to this damage to the endothelium, there is colonization of the bacteria and also the proliferation of that bacteria. So this is the first step. And the next, after there is damage to the endothelium, what is the next? There is formation of the sterile thrombi. So damaged endothelial surface, there is attract the focal deposition. As we know, there is damage endothelial injury with the sterile thrombus formation. So we know there is a sterile thrombus formation after. So damaged endothelial surface attract focal deposition of the platelets and fibrin, and there is aggregation of the platelets and the fibrin. And when the platelets and fibrin comes together and they form sterile vegetation, so there is sterile vegetation formation. So this is the sterile vegetation. And next, after that, after the sterile vegetation formation, there is adherence of the microorganism. So the microorganism which is present in our blood, so they gain access to the circulation and adhere deposit to the sterile vegetation. So these sterile vegetation become infection of the sterile thrombi. So the bacteria enter into this vegetation. After entering that vegetation, the bacteria undergo proliferation. So there is proliferation of the microorganism in that vegetations. So after the proliferation of that bacteria in that vegetations, there is formation of the thrombi. So this is the formation of the thrombi. So these are the pathogens because the vegetation may get detached and form infective emboli, so can cause spread of the infective to the visceral organs and the brains. So because this emboli is a combination of the organisms and antibody, means it's an immune complex. So this is a immune complex, so which can deposit it into the other body organs and infect the other body organs. And these are the pathogenesis and pathophysiology of the first. There is damage to the endocardial damage, and there is a sterile thrombus formation. After the sterile thrombus formation, there is microorganism can attack to these sterile vegetations and enter that vegetations. And after there is adherence to the microorganism and proliferation of the microorganism and formation of emboli. So these are the steps which involve in the pathophysiology of the infective endocarditis. So next is the morphology, features of the infective endocarditis. Grossly, if we see, there is the vegetations. These are the hallmark and pathognomic of the infective endocarditis, which have following features. So what are the features? Appearance, if we see, there is friable, bulky, potential destructive vegetations, less destructive in subacute than in acute endocarditis. So these are the vegetations on the damaged leaflets. As you can see, these are the vegetations. So maybe single or multiple change in the involved wall. So what are the changes which we can see in the involved wall? So there may be edema and inflammation. In severe cases, leaflets may perforate, causing regurgitation. So as we know, there is mitral stenosis, which vegetation on the wall. So these are the vegetations formed in the morphological feature of the infective endocarditis. So sites, so what are the most common sites if where the vegetation can form? So arterial side of the arterioventricular valves. So these can be asked in any MCQ question in any exams. What are the sites of vegetation formation in infective endocarditis? So please remember these points. And ventricular side of the semilunar wall, point of closure of the leaflets. These are the most common site involvement. So as we know, aortic valve with the large vegetations, you can see this is the aortic valve. So these are the vegetation which can form. So next we will discuss about the characteristics feature of the four major types of vegetative endocarditis. So what are those types? Rheumatic fever endocarditis, infective endocarditis, and non-bacterial thrombotic endocarditis, and Liebman-Sack endocarditis, which can be seen in SLE, systemic lupus erythematosus. So in rheumatoid arthritis, there is small warty vegetation along the line of closure of leaflets. So in a rheumatic fever, if we see, this is the wall closement and the vegetations. Here we can see vegetation on the line of closure. And the infective endocarditis, there is large irregular on the wall cusp that can extend to the chorda tendineae. So here we can see, in rheumatic fever, and here we can see in infective endocarditis. So line of closure we can see in rheumatic fever, and infective endocarditis we can see on the chorda. So chorda tendineae here. So these are the chorda tendineae. These are the fibrous structure on which the valve leaflets can attach. So they can also spread onto the chorda tendineae. And non-bacterial thrombotic endocarditis, there is small bland vegetation usually attached to the line of closure of leaflets. And Liebman sac, these are the small medium sized vegetations on the either side of the leaflets. So these are the characteristic features of four major type of vegetative endocarditis. So next is the clinical features of. So next we will discuss about the clinical features of infective endocarditis. So there, first of all, there is constitutional symptoms. What are those? Fever, chills, because it's an infection. So there is a presence of fever, chills in 90% of the cases, and also tachycardia. So tachycardia means there is heart rate more than 100 beat per minute. So we can see this is the tachycardia. There is an malaise, weakness, night sweats, and weight loss. Dyspnea, difficulty in breathing, cough, pleuritic chest pain, arthralgia, and myalgia also present. These are the constitutional symptoms. And next, what are the cardiac manifestation which we can see? So there is new heart murmur developed or changed to a pre-existing one. So what are the murmurs can see? as we know there is a mitral valve involvement, so mitral which can undergo the mitral regurgitation. If there is mitral regurgitation, we can hear holosystolic murmur. Holosystolic murmur, this murmur can be seen during the whole cycle, cardiac cycle. Means we can hear this murmur during whole cardiac cycle. That's why it's called holosystolic murmur. So where is the point? Loudest at the heart apex, which is present at the fifth intercostal space, uh, fifth intercostal space, and mid clavicular line. So here we can see radiate to the left axilla. If there is tricuspid valve regurgitation, there is also holosystolic murmur, but loudest at the left sternum border. And the aortic valve regurgitation, there is early diastolic murmur, loudest, which is loudest as the left sternal border. And the sign, there is also a sign of progressive heart failure, because now these valves will not work properly, so which can lead to the heart failure. And what are the features and signs? There is dyspnea, difficulty in breathing, because back pressure can lead to the edema and difficulty in breathing, and also there is edema, maybe pulmonary edema. Sign of acute cardiac decompensation, pulmonary edema. And there is arrhythmia, because those microabscess formation can microabscess can formation can disturb the conduction system. So there is abnormal conduction system, so that can lead to the arrhythmias. And suspect the perivalvular abscess in patient with infective endocarditis who develop a new conduction abnormality. So this new conduction abnormality can lead to the arrhythmia. Maybe a third degree atrioventricular block can be seen in the infective endocarditis. So these are the constitutional and the cardiac manifestation, which is most important you can diagnose in a patient of infective endocarditis. So next one is the clinical feature, in we will discuss about the extra manifestations of infective endocarditis. What are those? So these are caused by bacterial microemboli and the precipitation of the immune complex, as we see. So for example, this is our heart, so there is formation of small vegetations, as we know. So these vegetation through blood vessels, they can spread to other body organs. So as we know, what are those vegetation? Those vegetations contain immune complex. Immune complex, what is immune complex? We know it's microorganism, means antigen and antibody. So this immune complex can spread to other body organs. So these other extra cardiac manifestation is due to this immune complex deposition in other body organs and other body sites. So what are the manifestation we see? There is petechiae. Petechiae means there is bleeding below the skin, and especially the sphincter hemorrhage. What is sphincter hemorrhage? It's a hemorrhage underneath the fingernail. So due to this immune complex deposition. And genital lesions means small non-tender erythematous macules on the palm and the sole. So micro abscess with neutrophilic capillary infiltration area of the hemorrhage caused by septic microemboli from the wall vegetations. So genital lesion we can see splinter hemorrhage. And next one is the oslo nodules. So these are the painful nodules on the pads of the fingers and toes, can be immune complex deposition. And raw spots around retinal hemorrhage with pale center. So there is sign of acute renal injury, because if the immune complex can be if the immune complex deposited in the uh, renal artery in the so can lead to the acute renal injury, hematuria, anuria due to renal artery occlusion and the glomerulonephritis. If the immune complex that can deposit in the nephron or the renal parenchyma, can lead to the glomerulonephritis. And also if the complex can deposit it in the spleen, which can lead to splenomegaly and the possible right upper quadrant pain, because the spleen is present in the right upper quadrant. So due to this enlargement can cause the pain. And also there is neurological manifestation. So neurological manifestation may be like presence of seizure, there is seizure, paralysis, and due to any, because there is septic emboli, stroke due to hemorrhage, maybe due to meningitis, and encephalitis or abscess. So due to meningitis, encephalitis, and also due to abscess. So these are the neurological manifestation. And also there is sign of pulmonary embolism. So what are the sign of pulmonary embolism? Maybe there is presence of dyspnea, so difficulty in breathing. How it can cause? Maybe due to septic emboli result from the tricuspid valve involvement. So most commonly pulmonary embolism due to tricuspid valve involvement, which is related to the pulmonary circulation. And also maybe there is presence of arthritis. If the septic emboli involve the joints, can lead to the possible arthritis. So these are the clinical features. We discuss uh, constitutional symptoms, cardiac manifestation, and the extra cardiac manifestations. And the next we will discuss about the diagnostic criteria of infective endocarditis. So how can we diagnose? First of all, we diagnose through laboratory tests. Like we can do lab test. What are those lab tests we can do? So first of all, blood culture, as we know is a infection, we will do blood culture like oxalabinate, bartonella, so have negative cultures. And leukocytosis, we will see leukocytosis, in which there is increase ESR and CRP high will be high if we do blood culture. And the next is we can do echocardiography, which is the most important test we can do. So transthoracic echocardiography usually perform first, sensitivity is 75%, then the transesophageal echocardiography to confirm the finding like high sensitivity, then the TT. And the most important thing is modified Duke criteria, which is the most important for the diagnostic of infective endocarditis. So how can we diagnose? There is presence of, if there is two major criteria present, if there is one major and three minor criteria and five minor criteria is present, so we can diagnose the infective endocarditis. So this is important, which can be asked in any exam. So this is the modified Duke criteria. So what are the major diagnostic criteria to separate the blood culture positive for typically pathogen, and evidence of endocardial involvement, and valve vegetation or abscess on, and also new valve regurgitation. So these are the major diagnostic criteria. And what are the minor? Any predisposing underlying heart valve or IV drug abusers, fever more than 38, and vascular, any vascular abnormality present, if there is immunological or disorder, and microbiology of that patient with infective endocarditis. So these are the minor and the major criteria which we can use for infective endocarditis. So please remember these major and minor criteria. So as we said, if there is two major present, then we diagnose infective endocarditis. If one major and three minor, then we diagnose the infective endocarditis. If there is five minor criteria, we will diagnose infective endocarditis. Now we will discuss about the complication of infective endocarditis. So what are the cardiac complications and extracardiac? Due to the direct valvular damage and consequences of the local invasion, so there is formation of ring abscess, because valve, this is the valve, so there is formation of vegetations, so which can lead to the ring abscess. And a perforation and rupture of the valve or coda tendini, so rupture, and which can lead to the regurgitations. And also myocardial abscess, suppurative pericarditis, valvular dysfunction lead to the stenosis and insufficiency. So there is abscess, there is formation of fibrous tissue after the, when the inflammation heals, so which can lead to stenosis and the insufficiency. Then what are the cardiac extracardiac manifestations we see in infective endocarditis? Embolic complication due to septic emboli. What are the septic infarction like spleen, kidney, and brain? Mycotic aneurysm. So blood vessels can become aneurysm if the involvement. So emboli, if there is emboli, so which can make the blood vessel wall weak and lead to the mycotic aneurysm. And small emboli, microthromboemboli, may produce tiny hemorrhage lesions like splinter, subungual hemorrhage, and genuine lesions. Septic emboli from the right side of the heart, which can lead to the pulmonary circulation problem like pulmonary abscess and pulmonary embolism. And now, what are the immunological phenomena in infective endocarditis involving which can affect the other organs in our body? So we will discuss the this what first of all, there is focal segmental glomerulonephritis developed due to deposition of the antigen antibody complex in the glomeruli. Outer surface of kidney develop a flea-bitten appearance. Why? Due to patchy hemorrhagic foci involved in the glomeruli. So this, for example, as we see, this is our heart. There is vegetations, as we know, there is formation of vegetations. So these vegetation, if they involve artery, so through the artery they can enter the renal artery, and renal artery they can enter the kidney. So this is our kidney, so they can enter the kidney and lead to the glomerulonephritis, focal segmental glomerulonephritis. And ocular nodules and road spots are the retinal hemorrhage which can be seen in immunological phenomena due to the immune complex deposition in different organs of our body. So after in the last part of the infective endocarditis, we will discuss about the treatment plan of infective endocarditis. So what are the treatment if the wall is normal, healthy wall, native wall? So initial intravenous empiric treatment, antibiotic treatment with vancomycin we will start. And the duration of the treatment on the patient profile, we see if the patient profile is normal, and then we see is healing or not, then according to that profile we will continue the treatment. And 4 week treatment drug of choice is penicillin G, and alternative we use ampicillin, IV ceftriaxone, which is third generation cephalosporin, and IV vancomycin. So 2 week treatment are drug of choice gentamicin and the which is aminoglycoside and penicillin G. Alternative gentamicin, ceftriaxone. If the patient is IB abuser, so what are the drugs we can use? Intravenous empiric treatment with vancomycin. After confirmation of suspectable pathogen, we will use IV neficillin 2 week and per oral cloxacillin for 2 week. So next one is the prosthetic wall. If there is involvement of prosthetic wall, what are the drugs we use? Generally the same antibiotic regimen as for native wall, but longer duration, at least 6, we give longer duration. Okay, as we said, in native wall we give for 4 week or 2 week, but in prosthetic wall we give for 6 week, means it's a longer duration. Exception for staphylococcus aureus. Staphylococcus, if there is methicillin suspectable, we give neficillin, oxacillin, cefazolin, rifampin, and gentamicin. If the methicillin resistance, which is MRSA, methicillin resistant staphylococcus aureus, we give vancomycin, rifampin, gentamicin. If there is haekic organism, the drug of choice is the first line is third generation IV cephalosporin, which is ceftriaxone and sphotosime. And second line is ampicillin, sulbactam, IV fluoroquinolone. So what are the duration of therapy in this condition? Native wall infectious endocarditis 4 week, and prosthetic wall 6 weeks. So these are the whole discussion about the infective endocarditis, and thank you for watching this lecture.